Good afternoon, everybody. My name is David Patrician. I'm now a third-year resident in psychiatry. I made this presentation last year when I was primarily responsible for teaching this presentation. Today we'll be talking about emergency psychiatry and approach to psychiatry in the emergency department. These are the objectives for today's presentation. Number 1, list the factors that impact safety when seeing consults in the emergency department. Number 2, develop an approach to psychiatry consults in the emerge, both regarding adults and children and adolescents. Memorize the criteria for certification and become familiar with the signs and symptoms of neuroleptic malignant syndrome and serotonin syndrome. We won't be covering Objective 4 in detail here. I know UWorld has many questions about this topic, and they can do a better job teaching it than I can. So when you see consults in the emergency room, you won't be seeing them on your own. You'll have a whole team with you. This usually consists of a junior resident, so someone in R1 or R2, a senior resident, so someone who's in R3 or above, an adult psychiatrist whom you'll review adult consults with, and likewise a child psychiatrist whom you review child psychiatry consults with. There's often a psychiatric liaison nurse or a PLN for both adult psychiatry and for child psychiatry. And of course, security makes up a very important facet of seeing consults in the emergency department in terms of safety. So now let's talk about that. So generally speaking, there are 3 different variables to consider regarding safety in the emergency department. These are yourself, the environment, and the patient with whom you're about to see. In seeing consults in the emergency department, you need to be aware of the environment and be able to identify potential hazards. You need to be aware of the patient and watch for mental status signs, which might indicate developing aggression or agitation. And remember, whatever you bring into the room, be it a necktie or a lanyard, can't be used against you if someone were to become agitated or aggressive. So be practical when you're working in the emergency department. Always have help nearby, and if you're ever concerned, always ask security for more support. So here's a scenario. You're on call in the emergency department and your senior resident asks you to review a 34-year-old male who has just been brought in by police for assessment with an unknown psychiatric history. Police leave before you're able to speak with them, and the patient's nurse is nowhere to be found. What do you do? Before even meeting the patient, the data gathering process begins. You can review SCM, look for past discharge summaries. From there, you'll get quite a bit of information that you don't necessarily need to repeat on your assessment. This would be things like social history, past medical history, and of course, current medications can be found on the eHealth record viewer. So here your investigation reveals that the patient is named Mr. Smith, and he has previous history of antisocial personality disorder. You learn that he was recently incarcerated for assaulting a nurse in the Dubé Center 2 admissions ago. You decide that you feel okay to see the patient, and you go in to interview them. What do you do next? So before even going into the room, you're going to need to let the security officer know so that they can provide support and be aware of where you're at during your interaction with this patient. So you ask the security officer for support whilst interviewing the patient. You stand outside of the door with just enough space between you and the patient that the security officer is able to intervene if needed. You assume a gentle tone and ask direct questions as to avoid making the patient angry. Mr. Smith reveals that he has been using meth daily for the past several days, and you discern that he is currently unable to engage fully in psychiatric interview. This is a very common occurrence. You report your findings to your senior resident upon reaching the conclusion that further probing will be futile. Mr. Smith is held overnight for reassessment by the day team. And so you've played it safe and nothing bad happened in this situation. Adult consults are the most frequent you'll encounter during your shifts in the emergency department on psychiatry. Patients can be referred from an emergency physician, a family physician, or on a number of forms that are legal documents under the Mental Health Act. This includes a Form A, where if another physician has assessed the patient, contacted the attending psychiatrist, and there's been an agreement that the patient needs psychiatric assessment. Form C, this is also a judge's warrant, so someone has approached a judge and presented evidence that someone is suffering from a mental health problem and needs to be assessed from a psychiatrist. Section 20 is when they are brought in from police, so this could be someone who is attempting to jump off a bridge to their death. And a Form H7, so this is when a patient violates the stipulations in a community treatment order. So if they're instructed to receive an injection on a regular basis or to attend an outpatient psychiatrist appointment and they fail to do so, they can be brought in by police for assessment. So psychiatry consults take a long time. I don't think that's news to anybody. Ensuring that you use your time wisely will mean that you have more time for sleep on call. You want to ask the question, first off, what do we already know about the patient? Here you review SCM for previous notes. They can be a treasure trove for information, particularly if you're completing sections of past medical history, medications, and social history. Then you want to find the patient chart and use it. There's often useful information included on it, including judges' warrants and information pertaining to the detainment of the patient if they've been brought in one of those forms we just talked about. You want to use your electronic resources. So again, SCM, eHealth Viewer. These are places where you're going to find a lot of useful information about patients and helps you complete a lot of that documentation before you even see them. Next, sometimes the most challenging part is finding a place to see the patient. We work in a busy emergency department. Psychiatry patients aren't usually prioritized above others unless they are violent and need to be in an ICR. So now you're actually in the room with a patient. This is the information you absolutely need to get in order to have a complete psychiatric assessment. It looks like a lot, but if you use your time wisely, you should be able to proceed through it without much difficulty. Now, you're in a learning stage, so it's okay to take your time with consults, but realistically, someone else will have to check your work. You're not a resident, you're not a staff psychiatrist, so at this point, I think using 30 to 40 minutes to see a patient is sufficient. Get the information you need and come back and talk to the resident you're on call with. Once you're there, you can start typing up your note, and the resident can go and finish the assessment. They can come back, they can have that conversation with you, and there's time for learning. So essentially, what this means is go talk to the patient, get a general sense of what's going on, and come back. Then, together with the resident, you can complete the consult. Okay, here's another scenario. Mr. A has been referred to psychiatry under Form A. What does that mean? So we discussed this earlier. What it means is that another physician has assessed the patient, has contacted the staff psychiatrist, and they both agreed that the patient needs involuntary psychiatric assessment. So you've been asked to see this patient. What do you do first? Well, as we talked about, you go onto the electronic record, you look at SCM, you look at EHR, you get as much information about the patient as you can before you see them so that you're able to go in with your eyes wide open. So SCM reveals a recent discharge from the Deuce Bay Center, which is only 1 week old. He was admitted for substance-induced psychosis due to methamphetamine. You're able to acquire enough information to complete most sections of your note. So what do you do next? Well, you go and see the patient. So Mr. A is easily engaged in interview and appears fearful. He remarks frequently on the presence of the security camera in the room, and during your conversation, turns to tell an unseen individual to shut up. Given your assessment, you believe Mr. A may be suffering from psychosis secondary to meth use. Again, very common. Review with the resident, who recommends olanzapine 10 milligrams and reassessment later that night. Upon reassessment, Mr. A continues to endorse the above symptoms, and after discussing with the staff psychiatrist, you decide to certify him. What does certification mean? So on the left here, you see a brief summary of the criteria that need to be met in order to be certified. Here is the legal text from the Mental Health Act, which pertains to the same certification criteria. The person is suffering from a mental disorder as a result of which the person is in need of treatment or care and supervision that can be provided only in a mental health center. As a result of the mental disorder, the person is unable to fully understand and to make an informed decision regarding his or her need for treatment or care and supervision, and, as a result of the mental disorder, the person is likely to cause harm to himself or herself or to others, or to suffer substantial mental or physical deterioration if he or she is not detained in a mental health center. Okay, so you've decided to admit Mr. A. In order to do this, you have to call 8004 and provide the following details to the hospital. It includes location, last name, diagnosis, COVID screen, whether they're voluntary or certified, the diagnosis of admission, and noting any safety concerns, as well as the name of the on-call psychiatrist, so who you're admitting the patient under, and a way for them to get in contact with you if they need to, so either pager or a lot of us use cell phone these days. Then you have to complete the admission orders. These can be found on forms on demand. Remember to do things like nicotine replacement as well. This is often forgotten, but often called about if it is forgotten. You don't want people calling you all the time, so make sure to get some of those things done beforehand. Then you complete the fax cover sheet and show that note to the world. So you send it off to their family physician, their outpatient psychiatrist, and the on-call psychiatrist who initially gave you the consult. But you're not done yet. You have to make sure that you do a physical exam, because all patients who come into hospital need to have a few things checked out. This includes a respiratory, neurologic, and cardio exam in order to make sure that that patient doesn't have some underlying medical cause for their presentation, but also to make sure that they're safe and healthy or assured before they come into hospital for psychiatry. Oops, you're the wrong Mr. A. It turns out he's never been admitted before, and he rapidly cleared after receiving the olanzapine. So now you have to discharge him, but not without support. Some of the common supports we offer patients as we discharge them from the emergency department are things like transition team. This is a team of social workers generally who call to check up on patients after they've left. Referral to the rapid access clinic. So for patients who have never been referred to a psychiatrist before, they can have access to the rapid access clinic where they can see a psychiatrist in a relatively short amount of time. They can then be triaged and sent to a different psychiatrist after that has been completed. You may give them prescription medication. This needs to be faxed to their pharmacy, or it can be taken with them if you think that they are reliable enough to fill it. You can offer to connect them to centralized intake. This just means providing them a phone number so they can get in touch with a counselor. And then you have to give them return to care instructions that are quite specific so they know when they should be coming back. So now let's talk about the approach to child and adolescent psychiatry in the emergency department, which is pretty much the same as how you would approach an adult consult except for a few differences. So here the heads exam takes center stage, and there's twice as many people to talk to. So when you talk to a patient, they should ideally have a parent or caregiver present. You want to make sure you have time to speak to the child on their own. You also want to speak with the collateral person on their own, and then eventually you bring them both together to discuss the plan at the end. The plans are pretty much the same as before. The difference is that if you have to admit the patient, you have to do it under parental consent unless they're a mature minor and they're presenting independently. So unfortunately, suicide is really common, and it's one of the most common reasons we get consulted in the emergency department. Everybody should know how to do a suicide risk assessment, not just people working in psychiatry. A common tool is the sad person scale. Unfortunately, suicide is very common. Probably the best approach is to ask about what kind of thoughts they're having pertaining to suicide, if they've attempted before, how far they've gotten. Asking about specifics of plans are also very important. So as I said, we're not going to spend too much time talking about neuroleptic malignant syndrome here. Essentially what happens is you have dopamine blockade. It leads to a constellation of symptoms remembered with a mnemonic fever that develops over 24 to 72 hours. This stands for fever, encephalopathy, vital sign instability, elevated enzymes, rigidity of the muscles. It has a 5% mortality, so that's 1 in 20. Investigations you want to order are CK, CBC, white blood cell count, and looking for myoglobinuria. You can treat with dantrolene sodium and bromocriptine on exams. Dantrolene sodium is typically the correct answer. Similarly with serotonin syndrome, we're not going to talk too much about it, but what the problem is, there's too much serotonin. It leads to shivers, which is a constellation of symptoms remembered with that mnemonic. It develops over 6 to 24 hours. This stands for shivering, hyperreflexia, myoclonus, increased temperature, vital sign instability, encephalopathy, restlessness, and sweating. It actually has an 11% mortality rate. I feel like we often talk about neuroleptic malignant syndrome as being very scary and very high mortality rate, but in fact, serotonin syndrome is more than twice the mortality rate of neuroleptic malignant syndrome. So treatment often consists of stopping the offending medication, supportive care. On exams, ciprofloxacin is the answer. You can also provide Ativan or diazepam if the patient may benefit from that. So thanks for your attention. This is my cell phone number and my email. You can contact me at any time if you're interested in psychiatry or want to learn more about anything from psychiatry. If you're looking for a great residency program, I can't recommend ours enough. And if you want to do an elective, I can provide specific advice related to your career interests. So thanks for your attention. Have a nice Friday.